the parathyroid gland. The parathyroid gland. These glands, they are located in association with the thyroid gland. So depending on the species of animal, it could be in 1 to 2 pairs, and it functions to regulate the concentration of calcium ion in the blood by production of the PTH that increases the blood calcium level, and also calcitonin produced by the parafollicular cells that lower down the blood calcium level. So the parathyroid hormone is produced by the chief cell in the gland. Right. So first one is the hypo. In terms of the abnormalities, is the hypoparathyroidism. Hypoparathyroidism is associated with either subnormal secretion of PTH or the amount of PTH is normal, but the hormone failed to interact with the target cells. Usually hypoparathyroidism, this condition has been reported in small breed of dogs. Again, usually because of idiopathic causes. Where in the early stage, because this is idiopathic, in the early stage, usually it is you're gonna see infiltration of the lymphocytes and plasma cells. Okay, but as the condition progresses, the inflammatory reaction is going to be more diffuse in nature, with fibrosis and extensive degeneration of the chief cell, and eventually it leads to the entire gland will be replaced by lymphocytes, capillaries, or new capillaries, and fibrous tissues. Okay, this destructive hypoparathyroidism may develop from an immune-mediated mechanism. It can also, time to time, happen because of neoplasia. Mainly the non-functional neoplasia and long-term long-term hyper calcemia that eventually leads to secondary atrophy of the parathyroid gland. So the clinical signs associated with hypoparathyroidism is increased neuromuscular excitability and tetani associated with the lower amount of calcium. Then, of course, also less appetite, vomiting, diarrhea, and dehydration. This is associated with the abnormalities in the gastrointestinal smooth muscle contraction, and bone resorption. Bone resorption and modeling and bone modeling can also be abnormal. All right, mainly because of the blood calcium diminishes due to lack of PTH. So that is hypoparathyroidism. Next one is hyperparathyroidism. This is due to hyperparathyroidism due to primary causes, or you call it primary hyperparathyroidism. So the primary hyperparathyroidism develops in cases of adenoma or adenocarcinoma of the parathyroid gland, where the neoplasia secretes functional PTH in excessive amount than normal, which results in prolonged increase in the PTH in the blood circulation. So this will leads to prolonged rate of bone resorption by the osteolysis and osteoclastic activities, in which, for example, the osteoclast is like this. There are multi-nucleated cells in the bone marrow, and they are located in the Haumans, in a lacuna like this, right? Because they actively involved in bone resorption. So minerals will be actively removed from the bone, in which under the routine H&E, if the bone is poorly mineralized, it leads to lack of this eosinophilic staining in the bone matrix. Okay, or if you use special stain like von Costa, for example, you're gonna end up with a very poor positive staining, or complete lack of positive staining in the bone matrix. Von Costa positive stain should be should stain brown in color, right? So minerals are removed from the skeleton at an accelerated rate, and then it could be replaced by immature fibrous connective tissue throughout the skeleton. Like I previously mentioned, it is termed as osteodystrophia fibrosa, or fibrous osteodystrophy. That's it. All right. So adenoma of the chief cells is a common cause of primary hyperparathyroidism. This is usually affects only a single parathyroid gland, where grossly it appears enlarged, brown, and encapsulated. So because of this, because of the encapsulation, it has a very sharp demarcation from the surrounding thyroid gland. And histologically, you should be able to see a change of shape of the chief cell from cuboidal to round or polyhedral, and change of cytoplasmic color. Okay, about dark eosinophilic to pale eosinophilic. And in terms of the clinical signs, it is associated with lameness due to bone pain, or because of a fracture, pathological fracture, right? Because of lack of mineralization of the bone, and facial deformity, right, due to fibrous tissue replacement, hyperostosis, loosening or loss of teeth, anorexia, vomiting, arrhythmia, constipation, and whatnot. That is for primary hyperparathyroidism. Then the next one is secondary hyperparathyroidism. There are several different types or causes, but most important one are these three. The nutritional hyperparathyroidism occur commonly in cats, dogs, primates, horses, birds, and reptiles, where the hyper secretion of PTH is actually part of a compensatory mechanism induced by nutritional imbalance, such as diet low in calcium, right? So it leads to hypersecretion of PTH, or low in vitamin D3 that is important for the intestinal absorption of calcium. So when there's low in vitamin D3, it leads to low absorption of calcium from the intestine. It leads to a state of hypocalcemia. Then the parathyroid gland will try to correct this hypocalcemic state by secretion of PTH. So when there is imbalanced diet that results in hypocalcemia, yeah, the negative feedbacks basically stimulates the parathyroid gland, specifically the chief cell. Alright, next one is the for the hyperparathyroidism secondary to renal disease. It develops following a chronic renal failure, or sometimes called CKD, chronic kidney disease. The renal disease leads to reduction of the uh, glomerular filtration rate, and that retains phosphorus, leading to calcium and phosphorus imbalance. It also impairs the activation of vitamin D, vitamin D3, okay, that occur in the kidney. Okay, so it leads to diminishing intestinal calcium absorption. Again, almost similar like the same one for this particular part. And then that leads to hypocalcemia. So again, the parathyroid gland will be stimulated and will remain in the state of hyperfunction or hypersecretion of the PTH. Right. This is an example of rubber jaw or osteodystrophia fibrosa. They call it the rubber jaw because the jaw is rubbery in nature because of the fibrous tissue. So in this case, the face of the animal will be deformed. So it's sort of swollen. Okay, it can be bilateral. Sometimes it can be unilateral. Depends from case to case. Then yeah, largely because of the replacement of bone by fibrous tissue. Okay, because of the hyperparathyroidism. In acute um, hyperparathyroidism that develops following parturian paralysis in the cow, this particular condition is also known as the milk fever. But anyway, though it is called a milk fever, it is actually an afebrile condition, meaning that there's no pyrexia, there's no fever. So the production of colostrum and milk, so especially in dairy cattle that the high producer dairy cows, so it leads to peracute or acute hypocalcemia. So this leads to response by which the PTH is released, and then it leads to acute hyperparathyroidism. Although this is actually a part of the normal compensatory mechanism, but problem will happen when only when the compensatory mechanism reach its threshold. So the clinical signs pertaining to this hyperparathyroidism includes is associated with hypocalcemia, almost similar right? So they do have this, they do show this nervous syndrome like neuromuscular hyperexcitability, musculoskeletal weaknesses. So especially in this one, acute hyperparathyroidism or milk fever, you're gonna have this paresis and incumbency. And then the rest, it affects the smooth muscle of the GIT. So in ruminant, usually together with the together with the recumbency in ruminants, it leads to bloat, right, decreased intestinal absorption, and the rest. So that's it for my part. Actually, um, the general, which are the general principle, the adrenal, and the adrenal, the thyroid, and the parathyroid. The rest will be covered by Dr. Mazlina. Mm, do you have any question? That's number one. The next one is, do you want to have a well in the next session, for example, do you prefer to have a look at the like histology or histopathology of the endocrine diseases?
Yes, doctor.
So do you prefer to have a look at the ni Okay, I'll
Yes.
need to find a apa ni there's some images. I think I have some, but I need to re-select. Probably we can do that in the next session on apa Monday. Kan Monday, yeah. Next Monday. So that's it for today, unless you have questions.
Doctor,
Yes.
I have some question.
Mm,
So, what we know that in the follicular cell we have colloid, right, in the thyroid gland.
okay.
So what will happen with that fluid if there is a goiter or hyperthyroidism? So what happens to the fluid, to that fluid?
To that fluid.
Yeah.
If I'm not mistaken, for goiter, it's either the fluid, the colloid, there will be reduction of the colloid, or it remains the same. If I'm not mistaken, that colloid is part of the inactive hormone. The cells will take up the colloid for mean to turn it into an active hormone, usable hormone before they secretes into the orang panggil apa, vascular, to the blood vessel. Yeah. Then in hyperparathyroidism, if I'm not mistaken, it depends from cases to cases. It depends on the cause of um, parathyroidism. You may expect the amount of colloid to be similar or apa ni or increased. But increased production of increased amount of colloid, sometimes it can be difficult to appreciate since it's normal for the colloid to fill the entire lumen of the follicles.
So that's mean colloid ni dia tak ada function sangat lah.
They are like a reserve macam tu. Bila nak pakai, then dia akan take up for production of hormone.
Oh, okay. Understand. Thank you, doctor.
Alright. By the way, I think I did not upload upload the lecture lah dekat Putra Blast. Betul tak? I think I just uploaded the orang panggil apa the pathogenic mechanism, the first lecture, and the pituitary gland. Am I correct or am I wrong?
Yes, doctor. From the
Hey.
thyroid part, not yet.
Tak ada Alah, I need to apologize for this because I initially thought that I will cover the pathogenic mechanism, the principles, as well as the pituitary. But then I contacted Dr. Mazlina. Then she mentioned that she will cover pituitary. So because of this confusion, and then I forgot to upload the notes. Okay, tak apa. Later I'll upload. But anyway, if you have any question, you can ask now, or feel free to contact me. You can text me if you want. I'll try my best to address the question if I can. Do you have any more question? So I take the silence as a no. In that case, so we end our session, the today's session now. So I'll see you on Monday for the histo.
Okay, thank you so much, doctor.
All right.
Thank you.
Nice day.
Thank you, doctor.
Thank you, doctor.
Thank you,
Thank you,
doctor.
doctor.
Okay, then. Most welcome.